The portal vein is formed by the splenic vein and the superior mesenteric vein in the region of the confluence, which is quite near to the head of the pancreas. So we have another structure we are looking for, splenic vein, the superior mesenteric vein, which forms together the portal vein. We see this in the video clip. The portal vein, which reaches the porta hepatis, is formed by the splenic vein, and in this area, the confluence, it joins with the mesenteric superior vein and is directed towards the porta of the liver, and is the so-called portal vein. We managed to identify the arterial vascular tree, the abdominal aorta, celiac trunk, superior mesenteric arteries, and maybe also the renal arteries and the common iliac arteries. And we found the very important venous landmarks, the IVC, splenic vein, maybe also the renal vein and the caudal vein. We have to know the most important measurements of the aorta. The normal aorta is sized up to 2.5 centimeters in diameter. When the diameter exceeds 3 centimeters, it's an aneurysm of the abdominal aorta. And when the diameter is greater than 6 centimeters, there is an acute risk for spontaneous rupture. Also, when the diameter increases in a period of 6 to 12 months, more than 5 millimeters, there is also an increased risk for rupture. So, let's go on for some scanning. We scan the aorta in the longitudinal plane and follow its course from cranial to caudal. We can easily detect the liver in the near field, the spine in the far field, diaphragm over here. In this region we can detect the stomach, also very cranial. We can see another part of the stomach, the cardia of the stomach. Over here, pancreatic tissue is seen. And when we display the aorta, we can easily detect the first branch of the aorta, celiac trunk, over here, and only 1 centimeter below caudally the origin of the superior mesenteric artery, which follows the aorta in a parallel course from cranial to caudal. When we scan the aorta, we can easily see a very strong and bright hyperechoic wall of this vessel. And this single pulse movement over here. Gliding the probe only a few centimeters to the patient's right side, we detect another tubular structure, another great vessel of the retroperitoneum, the inferior vena cava, the IVC over here. How can we differentiate between the aorta and the IVC? Scanning the aorta, we see a very strong, bright echo of the vessel wall. We cannot detect any wall scanning the IVC. And the movement of the IVC is different to the one of the aorta. It's a double pulse movement due to the movement of the heart. We can also detect a changing of the diameter when the patient holds her breath. Please inhale and hold the breath for a moment. We can see while the patient stops breathing, the diameter of the IVC increases due to the increased pressure in the thorax, and go on breathing normally. And the diameter decreases when the patient goes on breathing. After we manage to scan the aorta in the longitudinal scan, we change to the transverse scan, transverse view in the epigastrium, turning the probe 90 degrees counterclockwise, and we start to scan the aorta in a very superior region of the abdomen. We can see lumbar vertebra over here, the pulsating aorta in midline, IVC on the right side of the midline, and so we go on scanning the aorta by moving the probe slowly, caudally. The first branch we can detect is celiac trunk with 2 branches, splenic artery to the left patient side and common hepatic artery to the right patient side over here. Celiac trunk, common hepatic artery and splenic artery. We follow the aorta to more caudally, and we can see the superior mesenteric artery in transverse scan, in transverse view, so it's round shaped like the aorta, and it's following the aorta to a more caudal region of the abdomen. Over here we can see the bifurcation at the level of the 4th lumbar vertebra, and we can easily detect the right and the left common iliac artery over here. Over here we can see nicely the bifurcation of the celiac trunk. We can detect splenic artery on the left side and common hepatic artery on the right side of the celiac trunk. When we move the transducer slightly caudally, we can display the superior mesenteric artery over here, and we can see our landmarks, the abdominal aorta, round shaped, IVC over here, lumbar vertebra, and in this view we also can detect the splenic vein, confluence of the vein, and pancreas over here. There is a small part of the stomach seen. So a lovely picture of the superior mesenteric artery. You have to look for the splenic vein. So we go on with the transverse scan, and we go for the aorta over here. We can see celiac trunk, caudally superior mesenteric artery, and superior to this artery we find the splenic vein, which drains the blood from the spleen on the left side over here. And in this region we will find the confluence where the splenic vein and the mesenteric superior vein joins to form the confluence of the portal vein, which takes its course into the porta of the hepatis over here. So once again, aorta, superior mesenteric artery, splenic vein, and over here pancreas, left liver lobe, the IVC, and in the far field we see the spine. The same way of scanning is used to find the renal arteries. We scan in the cross scan, transverse scan, and when we follow the aorta from cranial to caudal, we first detect celiac trunk, Then we can image superior mesenteric artery. And slightly caudally, we see these two origins of arteries over here on the right side and over here on the left side. These are the origins of the right renal artery and the left renal artery. And we can follow these arteries depending on the conditions of our examination quite well. Over here on the right side, over here, and on the other side towards the left kidney. I want to give you an impression how helpful ultrasound was for me and my patients in the clinical routine. There was a 70-year-old patient who was admitted for the operation on his gallbladder to our hospital. He told me of very intensive pain in the upper right quadrant and in the upper abdomen, so I scanned his gallbladder. I will show you. We can see the liver over here, the gallbladder, and some tiny gallstones, but I couldn't detect any inflammation of the wall of the gallbladder, so I scanned the retroperitoneum, and my eyes became wider and wider, and so did the diameter of the abdominal aorta of the patient. So I hurried to call my colleagues and to stop the planning of the gallbladder operation. There was a 7-centimeter abdominal aortic aneurysm present, and maybe the pains were caused by this vascular problem. And in the next scan, we also see color Doppler. This huge, tremendous aneurysm is filled with blood. And so a CT was performed, and you can easily see this great aneurysm, more than 7 centimeters in diameter, and at risk of rupture. So, an endovascular repair had to be done. A stent was placed in the abdominal aneurysm, and first we checked it with a contrast-enhanced ultrasound, and we saw contrast enhancing in the whole abdomen, the whole abdominal aneurysm. And after placing the stent, we repeated the examination, and there we can easily detect only blood flow in the stent, and this huge aneurysm has no vascularization anymore. Scanning the retroperitoneum is not easy at the beginning, but in short time you will detect the great vessels, and you will detect an abdominal aortic aneurysm before its diameter exceeds 5 centimeters. Don't give up. Rome wasn't built in a day.